Hi, thank you. It's really nice to speak today. So I'm going to be speaking about something slightly different, still in the realm of natural history. It's something that we learn as we're looking through our own cohort. So it's the non-accidental injury investigations in patients where there's subsequently a diagnosis of a rare type of EDS. So just to sort of set the scene, non-accidental injury, I know it has some other terms probably used differently in different places, but it really just describes the spectrum of injuries that are the result of sort of deliberate actions causing physical or emotional harm. And of course, this can affect a range of people, but we mostly see this in children. And often the thing that brings it to attention is sort of extensive or unusual patterned bruising. And so we see sometimes that these physical features of our rare diseases have the possibility, so they can present significant overlap with these features of non-accidental injury. And these can also therefore include the rare types of EDS. And we see in our cohort that there have been investigations of non-accidental injury, and then these patients have subsequently received a diagnosis, a genetically confirmed diagnosis of rare EDS. And I must emphasize, of course, these are very rare, infrequent cases where we're talking about sort of a non-accidental injury investigation and then a diagnosis, but these can have such a significant impact on the health and well-being of these patients. So this is sort of how we looked at our cohort. We had around or over 600 patients we looked through, and there were reports of non-accidental injury suspicion with investigation detailed in the histories of 11 patients. And these were split into 3 types. So we had patients from the vascular group, the classical group, and classical-like, and this was just one patient, they had type 2. And so we had sort of a baseline information from these patients, and we reached out to them to ask them some additional information, and just sort of detail below is the patients who we ended up speaking to when they were able to speak to us. So what can we learn from this group? So when suspicions were raised, nearly all of the patients, so 10 of these patients, it was bruising that brought it to attention. And suspicion was raised between 3 months of age and sort of 7 years of age. So a variation, but we're still talking very early childhood. And a range of services were involved in it. We had health visitors seeing maybe young children for weighing, or they were brought into A&E, or they saw their local paediatrician who raised the concern. So if we focus in on our vascular and classical patients, the majority, or nearly all of them, it was because of bruising to the legs and or the shins. We have one individual who was brought in for sort of, I guess at first it was seemingly a separate emergency admission, and they noticed this bruising, which is what caused the concern. And another individual where the initial suspicion was leukemia, and once this was ruled out, sort of they felt the next best fit was non-accidental injury. Slightly differently, we have our classical-like patient, and here they had recurrent dislocation of their hips, despite having quite a few stabilization surgeries. And during the hospital visits, they also, the clinician picked up on skin splitting and poor healing. And of course, this led them to be quite suspicious about whether there was something else going on. So in all of our patients, they had a subsequent diagnosis of EDS. But we know, clinicians are looking for a lot of different things when they come in, they may suspect this, and sort of this summarizes some of the types of things that they might be looking for. And some, you don't want to call something typical, but your first thought might be non-accidental injury. Some can't really be explained by anything else. But you have others that maybe there's a bit more of a blurred line, let's call it. So let's take a look at the soft tissue injuries. So if we're moving outside of non-accidental injury, there could be multiple, disorders that have features that could overlap. So we have the congenital bleeding disorders, which could cause some of these bruising that we see, leukemia, as we mentioned in another patient, and also your really ultra-rare diseases like Menkes disease. But out of all of them, features of connective tissue disorder often present quite a large and significant overlap here. And there are reports in some of the other types of connective tissue disorders. So we have osteogenesis imperfecta, and with these cases, it's often the fractures, and of course, that's something that we might think more about when we think about inflicted trauma. Fractures sort of, comes to mind. But we feel that maybe the soft connective tissue disorders are a bit overlooked. And outside of our own cohort, there's reports of non-accidental injury suspicion in other of the types of EDS, including brittle cornea syndrome. So it's not just the ones we've discussed, there's sort of a bit of a wider range there. And so I'll just sort of summarize some features that we know we will see across the EDS, those monogenic types, and then how this plays in relation to possible features of non-accidental injury. And you can see it's quite an extensive overlap. But I also think one thing that plays a part in this is the language we use around EDS features. Words like unexplained, spontaneous, extensive, recurrent. You may think from sort of an inflicted injury point of view, these are the type of things if you can't explain why it happened or why it seemingly happens for no reason. So I think maybe that plays a part in sort of where this confusion or sort of misunderstanding happens. So what can we learn from not only our own data but other reports? Individuals subsequently diagnosed with a rare type of EDS, this is seen across a range of EDS types, not just one, but we do see that often this is the result of the unexplained or extensive bruising, and that patients in our group reported little to no interrogation of their family history during investigation, so especially if it was their parents. So they were, even if they had similar features, they were not separately assessed, they weren't referred for assessment, it was sort of dismissed in their cases. And I think it's important to note, and we all know that, of course, family history is really important and really compelling when we're making a diagnosis of EDS, but a negative family history doesn't discount that, and we know that obviously we have our de novo variants, so it's something to bear in mind at least. And then with non-accidental injury suspicion, the investigations, of course, have a very long-lasting effect, especially where maybe this was misunderstood and this actually was a result of the EDS in these individuals. And I've just summarized some of the thoughts that our patients had reflecting on their experience, or the parents of patients reflecting on the experience that they've had with this. So of course, having these investigations and not reaching a diagnosis prolongs that diagnostic odyssey that patients go across. And then on the other side, we also have things like increased anxiety, both on the medical side and social anxiety. They worry what people think of them, and when this has happened, they develop quite a distrust in medical professionals because they're worried that people aren't going to believe what they say. And then also that oftentimes their first thought, even with a diagnosis now, is to postpone seeking medical help because they're really, really impacted by going and seeking help and then people suspecting them of something that didn't happen. So when we look back on it, what can we see as maybe the barriers? Why is this happening? Of course, infrequently, but what are some of the things maybe that we can address? So we have time, awareness, and guidance. Of course, genetic investigations in rare disease, they take time. We know this, we can't make it go any faster at the moment, and we want to act quickly when non-accidental injury is suspected, but we're limited in how quickly we can act on the sort of genetic side. Clinicians are less aware of rare types of disease, as we discussed before, this sort of how do we disseminate information. Most clinicians are not aware of these rare disease types, and they probably then won't think to consider them as an alternative diagnosis. And then can we provide guidance on rare diagnoses, and the importance, for example, of family history and really reinforcing this with clinicians who are sort of at the forefront of non-accidental injury suspicion. So what does this do? This really highlights the importance of effective communication between clinicians, of different specialties, especially then conversations with geneticists, and maybe things like MDT meetings can play a role in this. And a lot of the literature does show that we can differentiate between non-accidental injury and rare disease. But of course, we need to work with these barriers that we face to reach this. And then we just have to understand, you know, it's a really delicate process. We want to act carefully, but the impact that it can have on patients is really quite significant, both for them and their families, even after a diagnosis. And obviously, in doing this, we get this from natural history studies, so really looking beyond the clinical features and looking at the patient experience as a whole. So thank you very much.